Hi, I am Dr. Saqib Mansoor, and this is my channel Learning Anatomy. And today I will discuss with you the anatomy of the optic nerve. So you could see this is the optic nerve that is enveloped by the meninges and the CSF. So it is a atypical nerve, not a typical nerve, and it is an extension of the diencephalon. So here it goes. Here you could see this the two optic nerves over here, and this form the optic chiasma, the optic tract, and now ultimately they're going to the visual cortex for the interpretation of the image. And the optic nerve, it's the cranial nerve too. It's a special somatic afferent nerve which subserves our vision and pupillary light reflexes. Enters skull via the optic canal of sphenoid bone. So I told you already this thing. And origin of the optic nerve, fibers of the optic nerve are the axons of the cells present in the ganglionic layer of the retina. These converge on optic disc and exit the eye about 3 to 4 centimeters toward the nasal side of its center as optic nerve. Right? So I told you and showed you the figure. This is the optic nerve here being formed. Here you could see this. This is the optic nerve formation. Optic nerve fibers are myelinated, but the sheets are formed from the oligodendrocytes, not from the Schwann cells, since the optic nerve can be said to be a tract within the CNS, central nervous system. It is quite obvious while the oligodendrocytes form the myelin sheath around the CNS structures and the Schwann cells around the structures in the peripheral nervous system. So it is an extension of the diencephalon. This is the point second to that. Optic nerve leaves orbital cavity through optic canal and then unites with the optic nerve of the opposite sides to constitute the optic chiasma. Here you could see this. This is the optic nerve formation. Here you could see it. It's the crossing of some fibers, and its mechanism will be discussed very soon with you. And from here, you see this. Now let me catch my laser for more clarity of the pictures. Here's my laser. Optic nerve, optic chiasma, optic tract, and then this is the lateral geniculate body. Then the optic radiation is formed, and this goes to the visual cortex, area 17. And the optic chiasma is lying at the junction of the interior wall and the floor of the third ventricle. Anterolateral angle of the optic chiasma are continuous with optic nerves. You could see these are this is the optic chiasma. These are the anterolateral angle. They're continuous with the optic nerve, and the posterolateral angle are continuous with the optic tract. In the optic chiasma, the fibers from nasal half of each retina, including also nasal half of the macula, cross a midline and make an entrance into the optic tract of the opposite side. You see this nasal side. Let me zoom in for you. This here you could see this. The fibers from the nasal side. This is the field of vision is this here. Here you see this is the optic chiasma, and from this is the nasal half, and this is the nasal half, and the fibers from both these nasal halves cross in the optic chiasma. This is the fibers from the nasal side. This is the red color, and these are the fibers from the from the nasal half, and they cross in the optic chiasma. Whereas the fibers from the temporal half of each retina, that includes the temporal half of the macula, pass posteriorly in the optic tract of the same side. Let's see that as well. Let me zoom in again. Here you could see that. This is the temporal half. Here you could see this going to the same side. This is the temporal half, and this is going to that very side, same side, and they come over that in the optic tract of that very side. And the optic tract arises from the optic chiasma and travels posterolaterally around the cerebral peduncle. Majority of fibers now end as they synapse with nerve cells in the lateral geniculate body. Lateral geniculate body is a small projection from the posterior part of the thalamus. I showed you already, you could see again. This is the, you see the laser, this is the lateral geniculate body, right? So, and after this geniculate body, some fibers pass to the pretactal nucleus and the superior colliculus of the midbrain and are related to light reflexes, right? That I will show you from this picture. You could see this is the pretactal nucleus. Some fibers go to this pretactal nucleus, and some go here to this the superior colliculus of the midbrain. This is the superior colliculus. So a few words about the lateral geniculate body. Lateral geniculate body is an oval little swelling that projects from the pulvinar of the thalamus. It consists of 6 layers of cells on which the axons of the optic tract synapse. Axons of the nerve cells within the lateral geniculate body leave it to constitute the optic radiation. Here you could see this, right? Then this is the lateral geniculate body. Let's for more interest and absorption of the learners of anatomy, this is the lateral geniculate body, but it's a small projection from the pulvinar. It's a nucleus of the thalamus, and from here the fibers that go onwards, travel onwards, they constitute the optic radiation. And no, the optic radiation. Fibers of the optic radiation or axons of the nerve cells of the lateral geniculate body. Told you already and shown in the figure. The tract passes posteriorly through retrolenticular part of the internal capsule and end in the area 17, which is the visual cortex, Broadband area 17, which lies in the upper and lower lips of the calcarine sulcus on the medial surface of the cerebral hemisphere. Here you could see this. This is the visual cortex. Here you could see the visual cortex, left and right. And you could see this areas more specifically. This is the primary visual cortex, Broadband area 17. Right? This is it. This is the calcarine sulcus. Here you could see this is the calcarine sulcus. And also see these secondary visual cortex area 18. And the tertiary visual cortex area 19. The role of area 18 and 19, also known as the visual association cortex, is perception of color and recognition of objects. Now, very, very important neurons of the visual pathway and binocular vision. There are 4 neurons that conduct visual impulses to visual cortex. Number 1 is the rods and cones that are specialized receptor neurons in the retina. Number 2, the bipolar neurons that connect rods and cones to the ganglion cells. Number 3 are the ganglion cells. Their axon pass to the lateral geniculate body. And number 4, neurons of the lateral geniculate body. Their axons pass to the cerebral cortex. These were the neurons of the visual pathway and the binocular vision. So neurons of the visual pathway and the binocular vision discussion continues. What happens in the binocular vision? Of course, the binocular vision is by the use of 2 eyes. The left and the right fields of the vision get projected on portions of both the retina. You could see this is the left field of vision over here. This is the right field of vision over here, right? Projected on the both side of the right eye and the left eye. The image of an object in the right field of vision get projected on nasal half of the right retina and the temporal half of the left retina. I've shown you already this whole phenomena from this that the image on the object in the right field of vision. This is the right field of vision. This is the image. This is the temporal. This is the nasal, and this is projecting over here, and the nasal is projecting over here. And in optic chiasma, axons from these two retinal halves combine to constitute the left optic tract. Here you see this. This you could see. This is the one optic tract, and this is the one optic tract. Neurons of the visual pathway and binocular vision continues. Neurons of the lateral geniculate body then project to the complete right field of vision on visual cortex of left hemisphere, and then the left visual field on visual cortex of the right hemisphere. Right here you could see this was the left field of vision, and this is the right field of vision, and this is the left visual cortex, and this is the right visual cortex. Lower retinal quadrants, upper field of vision, get projected on the lower wall of the calcarine sulcus, while upper retinal quadrants, lower field of vision, get projected on the upper wall of the sulcus. It is said to be noted that the macula lutea gets represented on the posterior part of the area 17, and the periphery of the retina gets represented anteriorly. Now, I have to talk the very important visual reflexes. First of all is a pupillary light reflexes and pathway. Here you could see. And pupillary light reflexes result when light shines into one eye and it causes both the pupils to constrict. Number one is a direct pupillary light reflex, and number two is the consensual pupillary light reflex. What is the direct pupillary light reflex? It is the response in the eye that is stimulated. And the consensual pupillary light reflex, it is the response in the eye that is unstimulated. Afferent impulses travel through optic nerve, optic chiasma, and optic tract. That is the same figure you've already seen many times. At this point, a few fibers leave the optic tract, and then fiber synapse on nerve cells in the pretectal nucleus, which is lying close to the superior colliculus. Impulses are passed by axons of the pretectal nerve cells to the parasympathetic nuclei, Edinger-Westphal nuclei of the cubulomotor nuclei, third cranial nerve on both sides. Now the fiber synapse and the parasympathetic nerve travel through the oculomotor nerve to the ciliary ganglion in the orbit. So let's see this figure. Here you could see this is the mechanism. So I've shown you already, and let's see again. But this is the pretectal nucleus, and fibers from here pass to this. You can see the oculomotor parasympathetic nucleus of the cranial nerve 3. Here you could see this Edinger-Westphal nucleus on the both sides, also on this side and on this sides. And they also pass to the ciliary ganglion, and let's see that as well. You see this is the pretectal nucleus. This, you could see this labeling, and it's going upwards to the ciliary ganglion. Here you could see this is the ciliary ganglion. Here you could see this, and going on the both sides. In the final place, postganglionic parasympathetic fibers travel through the short ciliary nerves to the eyeball and to the constrictor pupillary muscle of the iris. Right? That I show you also in the zoom position. This is the short ciliary nerve going from the ciliary ganglion. From the ciliary ganglion, short ciliary nerves go and they act on this constrictor pupillary muscle of the iris, right? This is responsible for the light reflex, and it occurs on the both eyes. Both pupils get constricted in the consensual light reflex due to the reason that the pretectal nucleus sends fibers to the parasympathetic nuclei on both sides of the midbrain. I've shown you in the picture and discussed that with you with a lot of clarity. Fibers that cross a median plane do so close to the cerebral aqueduct of the sylvius in the posterior commissure. That phenomenon can be seen as well. That this is the cerebral aqueduct, this diamond shaped, you can say, and here are the pretectal nucleus, and fibers are crossing very close to that go to the opposite side. Now the pupillary dilation pathway. Pupillary dilation pathway. It is mediated by the sympathetic division of the autonomic nervous system. Its interruption at any level results in the Horner syndrome. It comprises the following structures. Number one in this pupillary dilation pathway is the hypothalamus. It has neurons that project directly to the ciliospinal center, T1 and T2, of intermediolateral cell column. Number two in the pupillary dilation pathway is the ciliospinal center. Of course, it projects preganglionic sympathetic fibers via the sympathetic trunk to the superior cervical ganglion. Number three in this pupillary dilation pathway is the superior cervical ganglion, which projects postganglionic sympathetic fibers via the perivascular plexus of the carotid system to the dilator of the iris and to the palpebral muscle of the molar. Postganglionic sympathetic fibers pass via the cavernous sinus and enter orbit through the superior orbital fissure. Now the convergence accommodation reaction. It is essential for the visual fixation and acuity at close range. It is initiated by conscious visual fixation on a near-lying object or by a blurred retinal image. Number one, reflex changes. With accommodative effort, 3 reflex changes are started. Number A, convergence. It occurs at the eyes. It occurs as the eyes focus on a near point. The eyes will converge. It is mediated by medial recti innervation via the third cranial nerve, which is the oculomotor nerve. And its second part is the, after convergence, it is the accommodation. It is adjustment of eye for various distances. It occurs as contraction of the ciliaris causes in a thickening of the lens and increase in the refractive power. It is mediated by accessory oculomotor nucleus via cranial nerve 3, the oculomotor nerve. Its third component after accommodation is, first is the convergence, then is the accommodation, and the third is the pupillary construction. It causes an increase in the depth of the field and the depth of the focus. It is again mediated by the accessory oculomotor nucleus via cranial nerve 3, oculomotor nerve. In the convergence accommodation pathway, visual, number one is the visual cortex, area 17, it projects to the visual association cortex, area number 19, the Broadman's area. And number two is the visual association cortex, area 19, Broadman's. It projects to the corticotactal tract to the pretectal area of midbrain. Number three is the pretectal area. It projects to nucleus of Purlia. That's what is the nucleus of Purlia. This is a whole pathway. Visual cortex, visual association cortex, pretectal area, and now the nucleus of Purlia. It projects to rostral and caudal accessory oculomotor nuclei and medial rectus subnuclei of the cranial nerve 3. It is called the convergence nucleus. So the nucleus of Purlia is called the convergence nucleus. Now the corneal reflex. Corneal reflex results due to the corneal reflex results blinking of the eyelids when the cornea or conjunctiva are touched lightly. Afferent impulses from cornea or conjunctiva pass through the ophthalmic division of the trigeminal nerve to the sensory nucleus of the trigeminal nerve, which lies in the pons. Here you could see this. This is a cornea, slightly touched. You could see this area. And this is the afferent impulse going via the ophthalmic branch of the trigeminal nerve. This is the trigeminal sensory ganglia, okay? And going to the nucleus, main sensory nucleus of the trigeminal nerve lying in the pons. This is pons. And from there, this is the internuncial neurons comprising the medial longitudinal fasciculus, and they project to the main motor nucleus of the facial nerve, cranial nerve 7th, and the efferent impulses go through the orbicularis oculi and causes its constriction that results in blinking of the eye. Then the visual body reflexes. Automatic scanning movements of the eyes and head, which are carried out while reading. Automatic movements of the eyes, head and neck towards the source of visual stimulus. And the protective closing of the eyes and even the raising of the arm for protection are the reflex actions that involve the below discussed reflex arcs. Visual impulses follow optic nerves, optic chiasma, and optic tracts to reach the superior colliculi. From here, these impulses are related to the tectospinal and tectobulbar. These are the tectonuclear tracts, and to the neurons of anterior gray columns of the spinal cord and the cranial motor nuclei. Let's discuss from the this picture is beautiful. You could see this is the optic nerve constituting the optic chiasma. This is the optic tract. Then this relate to the lateral geniculate body over here and over here. And from this lateral geniculate body, tectobulbar, the tectospinal tracts originate, which go to the motor nuclei of the cranial nerves or to the motor neurons of the anterior gray column of the spinal cord, which is the final common pathway. Pupillary skin reflex. What is that? Pupil will get dilated if the skin is pinched painfully. Afferent sensory fibers are said to have connections with the efferent preganglionic sympathetic neuron in the lateral gray columns of the first and second thoracic segments of the spinal cord. Wide rami communicantes of these segments travel to the sympathetic trunk, and preganglionic fibers ascend to the superior cervical sympathetic ganglion. Postganglionic fibers pass via the internal carotid plexus and long ciliary nerves to the later pupillary muscle of the iris. And some very important clinicals of the optic nerve. First of all is the clinical examination. In the clinical examination of the optic nerve, at first ask from the patient if there is any change in their eyesight. Ask and check the visual acuity. It is to be tested for both distant and near vision. For near vision, tested by instructing the patient to read a card given to them that has a standard size of type. Each eye is tested turn by turn with or without the spectacles. Distant vision is tested by instructing the patient to read Snellen type from a distance of 20 feet. Then the visual fields should then also are to be tested. The examiner and the patient sit while facing each other with a distance of 2 feet. Patient is instructed to cover the right eye and examiner covers his own left eye. The patient is instructed to look into pupil of the examiner's right eye. Then a small object is moved in an arc around periphery of the field of vision, and patient is asked whether they can see the object. Extent of patient's field of vision is compared with the normal examiner's field, similarly to the other eyes tested. Then after that, it is very important not to miss loss of impairment vision in the central area of the field, which is called central scotoma. Note that again, central scotoma is the loss of impairment of vision in the central area of field. And I know a very, very interesting and important lesion of the visual pathway. For beginners of anatomy, it seems difficult for, but after my discussion with you, it would be very, very easy for you to learn this anatomy, the lesion of the visual pathway. Yes, lesion of the optic pathways can be due to various diseases, expanding tumors of the brain and the neighboring structures, such as the hypophysis and the meninges, and the CVAs or the cerebrovascular accidents are usually a cause. Most widespread effects on the vision take place where nerve fibers of the visual pathway are packed tightly together, such as the optic nerve or the optic tract. Number 1, circumferential blindness. What is that? This is blindness in the shown. Number 1, this is the blindness, circumferential, shown in the this color, black color, right here. This is the circumferential blindness, and these areas which are the shaded or colored dark, there is no vision. This is the circumferential blindness. Why it happens? This is a result of the hysteria or optic neuritis. Optic neuritis can ensue following spread of the infection from sphenoid and ethmoidal sinuses. The optic nerve gets infected while passing through the optic canal to enter the orbital cavity. Now the number 2, total blindness of one eye, which follow when there is complete section of one optic nerve, right? This is complete section of one optic nerve. Here you could see, and there, this is the right visual field of vision, telling you. So this is the complete loss of vision on one side. On one side, there is complete section of the optic nerve. This was a neuritis, optic neuritis. Then number 3, there can be nasal hemianopia. First, you see, this is the nasal side, this is the temporal side. In white is the temporal side, and in this dark is the nasal side. So nasal, this is the nasal hemianopia. Nasal hemianopia will result from a partial lesion of the optic chiasma on its lateral side. As you see, this is the optic chiasma, and this is the partial lesion. Number 3, partial lesion of the optic chiasma, resulting in this nasal hemianopia. This is the nasal hemianopia, and this is the partial lesion of the optic chiasma. And then bitemporal hemianopia, number 4, bitemporal. This is the temporal side. This is the temporal side. No vision here. This is blindness, bitemporal. And this is the, normal vision over here, normal vision over here. So this would be the bitemporal hemianopia, right? Half of the eye is lost. This is hemianopia. Bitemporal hemianopia will result from a sagittal section of the optic chiasma. Here you could see what happens in this bitemporal hemianopia. Number 4, this is the sagittal section of the optic chiasma, right? And this condition is usually a result of a tumor of the pituitary gland exerting pressure on the optic chiasma. Then number 5 to 7, you first see this number 5, 6, and 7. Number 5, what happens over here? This is again the loss of vision on the temporal side, loss of vision on the temporal side, loss of vision on the temporal side. So this is called as the homonymous. The exact word is the homonymous hemianopia. Contralateral homonymous hemianopia will result from division of the optic tract or optic radiation or destruction of the visual cortex on one side. This is the lesion, and the lesion cause the same hemianopia for both eyes. That is the homonymous hemianopia. If the right optic tract is divided, for example, a left temporal hemianopia and a right nasal hemianopia will occur. Let's discuss again. This is number 5, and the section is that of optic nerve. Sorry, optic tract. This is the optic nerve was that. This is optic chiasma. This is optic tract. These lesions are discussed super. And this is number 5, lesion of the optic tract. This is, you see, number, this is, you see, number 5. This is the bitemporal, contralateral, hemianopia. This is the homonymous, contralateral, homonymous hemianopia. Right? So this is the word, homonymous hemianopia. This is also, so the homonymous hemianopia results from number 5, 6, or 7. Number 5 is the lesion of the optic tract. Number 6 is the lesion of the optic radiation. And number 7 is the lesion of the visual area or the visual cortex. Now, this is very interesting. And this I wanted to discuss with you definitely, that the homonymous quadrantanopia, lower right homonymous quadrantanopia and upper right homonymous quadrantanopia. Why it occurs, right? You see this is the lateral geniculate body. And over here, this you see, this is the, you see, this is the calcarine sulcus and superior bank of the calcarine sulcus. This is the superior bank of the calcarine sulcus. And this is the inferior bank of the calcarine sulcus. And this is the lesion A over here. This is the visual radiation lesion in the here. And it occurs and due to the there is a lower right homonymous quadrantanopia. And in lesion B of the visual radiation to inferior bank of calcarine sulcus, there occurs upper right homonymous quadrantanopia. Examination of the funda. This is now ocular fundus is examined by the use of an ophthalmoscope. Patient is instructed to look at a distant object. During the right eye examination, the physician should use their right eye and hold the ophthalmoscope in their right hand. Physician systematically examines the fundus, looking first at the ophthalmic disc, then at the retina, then at blood vessel, and in the last at the macula. Optic disc looks creamy pink and its lateral margin is seen clearly. The center of the optic disc is pillared and hollowed out. The retina looks pinkish red and there should be no exudates or hemorrhages. Blood vessels consist of 4 main arteries with accompanying veins. Examine with care the AV, the arteriovenous crossings. The veins should not be indented by arteries. Macula is to be examined by instructing the patient to look directly at the light of ophthalmoscope. It looks slightly darker than the retina that surrounds it. In the last, we'll discuss very important papilledema. It results when there is increased intracranial pressure, for example, due to a tumor. Papilledema is a choked optic disc. It will take place. When it gets constricted, axonal degeneration takes place called optic atrophy, right? When the optic disc gets constricted, axonal degeneration takes place, which is called as optic atrophy. Thank you very much for watching my video, and I hope you like it, and you do subscribe and share. Thank you very much.